Hey everyone.
Hey Randy, how you doing, man?
Good. How's everyone doing? Hi, Dr. Toms.
Hello, how are you?
Good. Thanks so much for being a part of this.
Well, we'll see how it works out. I just slapped together some slides quick and then tried to get out of the OR in time to get here today. So,
Well, that's the way we like it. Fast and loose on Tumor Talk.
yep.
But I think we're just waiting on Jason. We'll get started. Sometimes he shows up a little late, but we can get started without him. We'll get started at 4 o'clock sharp.
No worries.
And then I think at the end, the Novacure people want about 3 minutes of time towards the end. Just give a little talk.
So how much time do you want me to go for? I've got about 25, 30 slides.
It's up to you. Typically what we do is about 15 to 20 minutes of presentation.
Okay.
And then we'll ask a few questions and kind of open it up to, discussion.
Okay. So I'll go through the slides relatively fast. And
sure.
Audience, what's the kind of mix of demographics that you're getting for the audience?
Oh, it ranges. We have a clinical audience. We have student audience. We've got people from patients. The patients will come in. So it really runs the gamut. So.
All right. So I'll keep it kind of medium level then and not try and make it too techie a talk. Jason, how are you?
I'm well. Thanks for joining us.
Sure.
Hey, Jason. So we'll wait one more minute and then we'll get started.
Okay. Somebody else do the intros and then I'll take over the screen and then ramble through the slides.
Perfect.
All right. Sounds like a plan.
And we'll live stream this as well and then bank this on the YouTube channel. So you'll have the hits that you get today as well as hopefully others to follow.
As if I really monitor them.
I think I'm going to.
We do.
Yeah, we do.
Well, that's good, Jason. That's good.
Give me 1 sec. I'm going to pull up a slide real quick, an intro slide.
I threw the intro slide on mine as well.
Oh, you have it on yours?
Okay. Yeah, we built it in. Dr. Tom took care of it.
We'll do it all at once then. So it's 4 o'clock. Why don't we get started? Welcome everyone to another edition of Tumor Talk. This is a joint collaboration between Lenox Hill Neurosurgery and the Journal of Neuro-Oncology, where we like to highlight recently published articles in the Journal of Neuro-Oncology and kind of get discussion, an open discussion with the author, as well as have an interactive discussion with our participants. As Dr. Sheehan was just mentioning, all these talks will be both live streamed on Instagram and YouTube and then preserved there for posterity's sake. And you can share the conversation with whoever you like. Today, we're fortunate enough to have Stephen Toms with us, and we'll be discussing tumor treating fields and a recent paper he published in the Journal of Neuro-Oncology. Today's session is one of our special sessions. It's sponsored in part by Novacure. And so we'd like to thank them for contributing to the NREF and the Journal of Neuro-Oncology as well. And so without further ado, Dr. Toms, please enlighten us.
Well, I'll do what I can to enlighten. Let's see how we do this. We'll go to share screen here. See if we get there and go back to slideshow, maybe. And back to the top. All right, well, thanks everybody. Hopefully the audio visual will be reasonable from my Mac here in the back of my office and everybody's staying safe during COVID era here. Today, we'll be talking about a paper I did that was a post hoc analysis of the EF14 trial, which was a phase 3 trial looking at Novacure tumor treating fields in addition to standard of care versus standard of care alone in the upfront treatment of glioblastoma. This work was done in combination with doctors Kim and Nicholas, as well as Viram from Israel. And I want to thank Jason Sheehan from Journal of Neuro-Oncology, Randy D'Amico and Nitesh Patel for hosting. So as we said, we've been through this, so we'll move right along and I'll give a little bit of background for those who aren't neurosurgeons in the field. That glioblastoma is the most common and prevalent adult nervous system cancer. We see about 13,000 or so glioblastomas in the US every given year out of about 23,000 gliomas. And there are some things that we as surgeons can impact, such as the age, the DNA methylation status, mutational status of the tumor. But the one thing we can still impact as the barbarians in the field is to try and get the maximum extent of resection we can surgically. When we do our very best and give our patients standard of care, which these days includes radiation about 54 to 60 gray and concomitant temozolomide, we get a median survival of anywhere around 15, 16 months for the glioblastoma. And again, the best survival depends on maximal surgical resection, temozolomide treatment, and obviously those who have a methylated MGMT tend to do much better, in the order of 5 or 6 months survival, better than those who are unmethylated. And we try and treat radiation to the resection cavity plus a couple centimeter margin around the edema or infiltrating tumor that's seen on the T2 weighted MRIs. And with this, we get a median survival these days of about 14.6 in Dr. Stroop's original paper in 2005, and now that median is pushed out to about 16 to 17 months in most studies. But glioblastoma has been a challenge I've worked on all my life, as well as Dr. Sheehan and many others on this talk. One of the problems is that all the tumor that we see on MRI that lights up with gadolinium is fairly compact, and surgeons such as myself can take those out. There's a large amount of infiltrating tumor around the border. So surgery is effective at removing the compact tumor, but not the infiltrating tumor cells as they infiltrate into functional brain. The blood-brain barrier keeps out many of the chemotherapies that we would like to deliver. Fractionated radiotherapy is only marginally effective as well. And then if we really look carefully, and something my lab's been working on for the last 8 or 10 years, is that there's a subgroup of stem cells that can be epigenetically modified by the microenvironment. And within those, a treatment-resistant fraction of cells that really is mostly responsible for the migration and the poor outcomes we often see. So when we look at glioblastoma, we really have both regional as well as systemic therapies that we can use and control. Among the local therapies that we have are those that we can do as surgeons with surgical resection. Radiation therapy is essentially a regional therapy, whether it's given in traditional fractions as image modulated radiotherapy or with stereotactic radiosurgery. And then we'll talk a little bit today about another local regional therapy called tumor treating fields. Systemically, our systemic treatment is primarily worked on chemotherapy. Unfortunately, our chemotherapies have only been marginally effective. Immunotherapy and immune-targeted therapies have shown a lot of promise in a number of cancers, but glioblastoma thus far has been quite resistant. And unless or until we get further with our dendritic cell vaccines, some of our other immunotherapies, whether they be virally mediated or CAR T cell, we still don't have very good systemic therapies for glioblastoma. Now, when we look at the National Cancer Center guidelines for treatment approaches of newly diagnosed glioblastoma, for those who are younger, which is classified by NCCN as less than age 70, we prefer to consider a clinical trial for these patients, but our standard of therapy includes that brain radiotherapy with concomitant temozolomide, with or without tumor treating fields. And this happens whether they're methylated or unmethylated. When patients are older, we have the option of omitting radiotherapy altogether, or going with omitting the chemotherapy altogether, or going with a hypofractionated chemotherapy, because certainly some of the older patients cannot tolerate the combination chemo radiation as well as some of the younger patients. And again, both for methylated and unmethylated patients, tumor treating fields are considered a category 1 possibility in the treatment. So for the uninitiated, what are tumor treating fields? And I remember when I first heard about this when I was back at Cleveland Clinic probably 16, 17 years ago, I was a little stunned to hear that an Israeli scientist thought that we could apply electrical currents to the brain that could seem to stop cell division and specifically work against glioblastoma. So the original trial, the F11 trial, looked at tumor treating fields in recurrent glioblastoma versus standard of best recurrent chemotherapy, and seemed to have some equipoise. Around that time, the basic science of how tumor treating fields was working was also advancing, and it seemed to show that the electrical currents that are applied in alternating fields that travel between the electrodes, either anterior-posteriorly or medial-laterally, and vary every second, seem to work on a number of the polar molecules in the brain, such as tubulins and septins that are involved in the mitotic spindle, attaching to the chromosomes and helping them equally segregate during cell division. When the tumor treating fields are present, it can disrupt that mitosis and either cause cell death via apoptosis or often a cell cycle arrest and blebbing. And then it's unclear, but there may be a bit of an immune component by exposure of some neoantigens from the cell during this blebbing that aid the immune response in TT fields. Of course, that's still a little bit up in the air at this moment. Now, one of the interesting things about how tumor treating fields work is that the frequency at which the tumor treating fields are best found is inversely related to cell size. So larger cells work when you give a lower frequency tumor treating fields, they inhibit mitosis, whereas smaller cells, like small cell lung cancer, need a higher frequency of about 240 kilohertz. For glioblastoma, the tumor treating fields device delivers 200 kilohertz alternating fields. And as you see, for mesothelioma, the other FDA approval for this device, it's a slightly lower kilohertz at 150 versus 200. So as we had mentioned, tumor treating fields are delivered via a portable battery device and transducer, and they deliver low intensity, about 1 to 3 volts per centimeter, intermediate frequency, 200 kilohertz, alternating fields in a couple of different directions. They are applied through the electrodes, which you see on this patient model head, and through the transducer, which you see below. Tumor treating fields are customized per patient. MR data is transmitted through a specialized software, which shows where the arrays should be set. Now, many of us, radiation oncologists and neurosurgeons, are used to giving gamma knife or other stereotactic radiosurgery, where moving your collimator a couple of millimeters makes a big difference. But here, the electrodes can actually easily be moved a couple of centimeters, and because of the relatively longer wavelength of the energy, only has a minor impact on where tumor treating fields are delivered in the brain. So the original trial, led coincidentally enough by Roger Stoop, and was published a couple of years ago in JAMA, showed a schema where after the original 6 weeks of concomitant temozolomide and radiation therapy, a 2-to-1 randomization schema was undertaken to try and deliver tumor treating fields with the device being turned on at least 18 hours a day, or 75% of the time, until second progression or up to a maximum of 24 months. Versus 6 months of adjuvant temozolomide. It was stratified by resection status and as well as MGMT status. And in the intent to treat population, it showed an additional survival of a little over 4 months, and moved the median survival from about 16 months to 20.9 months. Now remember, this was from the time of randomization, so the time of diagnosis actually pushed median survival in this group out to a little past 2 years at 24.5 months. Not unsurprisingly, when subgroup analysis was taken, the methylated group did better with their overall survival at about 31 months versus 17 months. Gross total resection was still better off than partial resection or biopsy, but interestingly enough, the biopsy patients tended to do a little bit better with a lower hazard ratio than those who were treated versus those who were untreated. The general functional analysis of the patient didn't show any decline in the quality of life, as many patients who treat glioblastoma know. The biggest decline we get in quality of life tends to occur from tumor progression near the end of life. And despite having to carry around a 2.5-pound battery pack, which actually weighed about 4 or 5 pounds back then during that trial, we didn't see much deterioration in the quality of life. And in fact, it stayed pretty consistent during the entire treatment. So when we really, what the paper that was published in Journal of Neuro-Oncology last year looked at was to see if there was any impact of compliance on how patients did. And what we did was tried to break down in a post hoc fashion to look at the EF14 patients, all 695. Of those, we had enough data on compliance to evaluate 450 patients who got tumor treating fields and 229 without, and then broke them into the different deciles of compliance, from less than 30% up to greater than 90%. When we really looked at these, we found a trend of improved survival no matter how far we went, and that those who wore the device more than 80 to 90%, and those who wore greater than 90% tended to do much better than those who wore the device only the median. In addition, we found that those who wore the device less than 50% of the time probably were not having much impact on their overall survival. Remember that tumor treating fields are an electrical device, so it's either on or off. If the device is off and that cell takes 2 or 3 hours to go through mitosis while the device is off, it doesn't have the chance to impact that particular cell division. So when we look at the progression-free survival and the overall survival of those in that highest decile, and again, remember, this is a relatively small group of only about 43 patients out of that total of 695 who were involved in the tumor treating fields device, and the 450 who were evaluable who wore the device. So only about 10% were able to wear it for this long. We did see an increase in both progression-free survival and overall survival that was quite measurable from the median. It increased the overall survival by about 4 months over those who were wearing the device a median of about 75% of the time from the original trial. And if we map this out, we see a fairly interesting phenomena that we've seen in several other pieces of data out there, although primarily in the immunologic data. On the interim analysis, the DCVax, if we look at the poliovirus data from Duke, both of those studies seem to have an interesting tail of about 20 to 30% long-term survivors that fell off early in the data and then sort of stabilized at about 3 years, and we didn't have many people fall out from that point. And interestingly here, in that group of patients who wore more than 90% of the time and of tumor treating fields, by year 3, we didn't see any further declines in survival. So it does suggest, that certain possibility, at least, that there may be somewhat of an immune mechanism that's activated during wearing of the tumor treating fields, and does pose the possibility that we'll find something further on as we start to evaluate this along with other therapies, such as our immune checkpoint inhibitors, or if we get further progress with some of the oncolytic viruses or the dendritic cell vaccines. Now, as one little addition, we also published another post-hoc analysis of the EF14 data looking at dose density, and this was published in the International Journal of Radiation Oncology and Biology and Physics. And there we started to look at something that we called dose density. We looked for where, doing a finite model analysis of where we predicted the electrical currents were running in these patients to try and map out where the voltage was highest and where the dose density was highest. And as we started to divide this between high voltage and low voltage, and here we arbitrarily picked greater than or less than 1 volt per centimeter, or the dose density of 1.1 milliwatt per centimeter cubed, we could see that there was an increase in survival in both of these when we had higher dose in the areas that were predicted to have tumor. And that included both the T1 weighted with gadolinium as well as the T2 weighted areas of the tumor. And when we really looked at dose density, which was a combination of both the power density as well as the patient's compliance, there was a stepwise increase that seemed statistically significant, that the more the patient wore the device and the better the device had high tumor treating field strengths in the areas where we would predict there was tumor, we seem to get increased survival as well. This is just a little map of showing where the baselines were, where there were high tumor treating fields on a patient with a left temporal occipital GBM. And you notice there was a little fall off in dose anteriorly with the way these electrodes were positioned. And sure enough, when the patient progressed, it seemed to progress in those areas of lower tumor treating fields. Dose. This is another way to look at that same thing, as we do sort of a heat map on the right versus where the progression was on the left. And certainly my own clinical practice, I saw this on a number of my patients on the EF14 studies, where I'd see sort of out of field progression. One was, an ipsilateral motor strip progression after a right frontal lobe tumor, another after a left parieto-temporal tumor progressed bifrontally in the basal frontal areas. And then when I moved the tumor treating fields up there, we got regression for a while before finally losing her. So I do think this does tend to show and overshadow some of the skepticism that people had early with tumor treating fields, if you look at both compliance and where the dose seems to be flowing, that there is a dose compliance and response curve here that we shouldn't be seeing if this was all hocus pocus, like I probably thought this was 15 years ago when I first heard about it. So in general, I think we can say that the NCC guidelines do offer tumor treating fields as an option, certainly, versus clinical trial or standard of care, whether the patient is methylated or unmethylated, regardless of age. We've seen that tumor treating fields have minimal toxicity, and most of those toxicities tend to be dermatologic, and tend to improve progression-free and overall survival versus the Stupp protocol or standard of care alone. And one of the last things that we've noticed in these couple of studies that we put together last year in the post-hoc analysis is that tumor treating field efficacy are influenced positively both by compliance as well as increased dose intensity in the regions of abnormality that correspond to tumor. Clearly, there are some obvious engineering things that could be done down the road that may be able to help with compliance and dose density. And I have to say, I've been pleasantly surprised over the last 15 years to see how effective this treatment has been in my patients. I've got a couple of patients who are on study who are past 10 years now, still doing well. Pleased to see that at least the science seems to be catching up with what seemed like science fiction when I first heard about this 15 or 18 years ago. So I want to thank everybody for their attention and hopefully open things up to a few questions here now.
Dr. Thoms, thank you so much. Fantastic talk. Really appreciate your time. I got, a number of questions. I'm super interested in this and understanding it better and whatnot. My main question is, how does changing position? So how do you guys target exactly? And then how often do you have to change where the electrodes lie, or do they go over the whole head?
So in brief, there's a proprietary program that the company has that allows you to figure out where best to position. So it's not too dissimilar from making a map for somebody for radiation therapy. You map out where the tumor is, and then this program shows you the optimal position of the electrodes on the scalp to deliver the highest doses around the region of interest that you identify, which is T1 weighted GAD plus the T2 weighted areas of tumor. So this is a long, relatively long wavelength compared to the energy used in ionizing radiation. So in ionizing radiation, if you move your collimators or if you move your energy source a millimeter or two away, you get vastly different dosimetry when you lay down your dose. But these wavelengths are long enough and cover so much of the head that the dose drop off from the highest concentration in the head to the lowest concentration is probably somewhere between 3 and 10-fold. So you can actually move the electrodes a centimeter to 2 in almost any direction without having a major, more than a 5 or 10% impact on what dose the tumor field, what dose of tumor treating fields you're getting over your region of interest in the brain. And that works out very well for patients because if they get any dermatologic issues, say there's a titanium plate underneath where one of the ceramic electrodes is sitting and they're getting a little sore there, they can move the electrode around a little bit without impacting their dosimetry much.
Well, what's the largest volume then that you would consider treating with one of these?
Well, you get a relatively high dose through most of the supratentorial brain. The way the dose tends to flow is, there's different compliances for the different electrical impedances throughout the brain. First, the scalp conducts reasonably well, but then you've got this great insulator around your head called the skull. In the center of the head is this big saltwater reservoir. And as most people know, saltwater is a pretty good conductor of electricity. So a lot of the current tends to flow down in and around the ventricles and flows around in that subventricular zone, which if you actually believe that the subventricular zone contains a lot of the more stem-like cells that might be involved in glioblastoma, you might think that's a relatively good thing. Now, no one's proved either of those hypotheses yet, but at least in my primitive brain, that seems like a relatively good thing. So down the road, you could imagine that if we can increase the amount of electricity we can push across the skull or find ways to direct the flow of the electricity a little bit better through the brain, we might be able to get more uniform flow of electricity across the brain. Now, I believe the company has also designed some newer electrodes that go down onto the upper neck a little bit to try and increase electrical fields in the posterior fossa. So there's been some interest in looking at these things in cerebellar disease and DIPG and things like that. But I haven't seen the data on that as far as how high those fields are versus what they're getting supratentorially. But supratentorially, you'll mostly get anywhere from about 3 volts per centimeter down to about 0.5 volts per centimeter. So it covers most of the supratentorial brain, but about a quarter of the brain or so is at that highest dose, and then it starts to fall off from there.
Excellent. We've got 2 good questions from the audience, actually. We've got one question. One participant asked, what are the possible complications from the treatment, specifically to healthy non-tumor brain?
Right. So far, this thing does not seem to work very much on any non-dividing cells. And one of the reasons it was first applied to the brain is primarily post-mitotic. Certainly, we've got some stem cells that are making it to the olfactory bulb, some to the hippocampus, and there's a little bit of new glial cells being made, but not a lot of new neurons. So the neurons are quite resistant to these electrical fields. I actually thought the device would start having trouble when they tried to apply it for things like ovarian cancer, where you've got a large amount of fields over the intestines. But if you go back to that slide we showed earlier, the intestinal epithelial cells are so large, they are optimized at about 50 kilohertz, whereas I think for ovarian carcinoma, they're using 150 kilohertz. And that differential means that 150 kilohertz does not impede or impair intestinal cellular mitosis very much. So they haven't had too many side effects. In fact, I had one case that went from a normal sized glioblastoma to a giant cell glioblastoma when it escaped. And when we moved the tumor treating fields over near that area, it really didn't respond very well, probably because of that cell size change that we had.
It's very interesting. Another question is, do the treatment fields have an effect on brain metastases? Obviously, I think we talked about different tumor types responding differently, but has anyone looked at this for brain metastases?
Well, there's actually an open trial right now called the METIS trial. It's been relatively hard to enroll and was close to closing down for a while, but I know we've fortunately enrolled 4 or 5 patients here in the last few months. And what they're looking at is stereotactic radiosurgery alone versus stereotactic radiosurgery plus tumor treating fields for metastases and lung cancer. It'll be curious to see. I certainly, if you look at the way tumor treating fields have worked, there's data. Obviously, they've been FDA approved for mesothelioma. There's some early data for lung cancer, ovarian, pancreas, and several other tumors. There have been some small trials I know that are investigator mediated for lymphoma and malignant meningioma. So this seems to be a fairly broad mechanism against cancer in general. I haven't seen any of the data from the METIS trial yet, and I don't have enough patients who are farther along in it. And honestly, we do relatively well with gamma knife and stereotactic radiosurgery for brain metastasis. So that's why it's been kind of a hard sell to that group right now. But I'm curious to see if it will reduce the incidence of at least newer metastases coming to the brain and becoming evident.
Yeah. In light of your compliance talk and the compliance paper, what are you telling your patients now? I mean, what are the impediments to compliance, and how are you talking to your patients and addressing these?
Absolutely. So
I was going to add. I think you're really the first to show that there's that incremental difference in survival with that improved compliance. So it really does drive patients, hopefully, to understand, and providers to understand the meaningful therapeutic gains that could be achieved, as your study would suggest.
Well, I got to tell you, Jason, I kind of came across the compliance thing by happenstance. We had opened the trial when I was at Geisinger, and for those who don't know, Geisinger is in a rural area, middle of Pennsylvania, even more rural than Jason at Charlottesville. So, and we had patients. Exactly. You've been there. That's right. You got a brother not too far away. So, we synchronized our patients coming back for their studies so that they could all meet together and meet during our patient wellness and gosh, why am I'm aphasic now after surgery, and our patient support groups. And what we found is that at the end of the month, every patient gets a little note from the company on their compliance. What percentage of the time did they have their device on? And when all of my patients in the study were meeting each other during their monthly meetings, they say, "Hey, Bob, how'd you do on your compliance last week?" "Oh, I did 82%. "Oh, that's pretty good, Bob. I did 94. I don't know if I'll be seeing you next month, but I know I'll be here." And we actually found that, not surprisingly, human beings like to compete. And when we give them data and give them feedback on how they're doing, our patient support groups tended to be the best motivator we could have. You and I could tell the patients 100 times that they need to wear it, but when they were getting feedback from their own social network on how they were doing, that I found to be the most important thing. The other part of it, I think, is consistent messaging. Certainly, one of my early patients on the trial who had a big butterfly glioma that I honestly didn't have much hope for. After about 9 months, the tumor had gone from a huge butterfly glioma to almost nothing that I could see. But he had an oncologist in upstate New York who kept teasing him about wearing that stupid electrical thing on his head. And he slowed down wearing it and then stopped. And within a matter of months, it came back. So I also found out that being on message for the whole treatment team is very important. If there's even one major skeptic out there, that can really undermine the patient compliance. And unless and until the whole team is on board with it, it's a hard enough sell, because I tell patients that, like climbing a mountain, you've got to be committed and you've got to have that village. You've got to have have a good Karnofsky really helps, and have a good family network of support around you to help with the compliance and getting plugged in and the batteries and goading you to take care of it. But once they get into the routine of doing it all the time, of every 2 or 3 days, taking the electrodes off, getting a good shower, shaving the head, putting them back on, plugging in, checking your compliance. It can sometimes be hard to get people to stop even when it's not working. And I've had more trouble getting people to stop once they've been on a couple of years and it's clearly not working anymore than I do have with getting them to start.
So what's the battery pack life like? Well, you just brought up some of the kind of day-to-day.
So the batteries last about 2 or 3 hours with normal use. So if you're going to be out for a day, like I had one who was a computer science professor, and he'd bring 3 or 4 batteries with him. So, when he was out lecturing and doing his work and doing office rounds and things, he could swap the batteries in and out. And then when they're back home, they can plug in while they're watching TV and sleeping. So it's
car adapter yet or not yet?
What's that?
Do you have a car adapter yet or not yet?
We'd have to ask the company whether they're coming up with one of those yet, for those with long commutes in LA and New York, I guess. So, yeah. Sounds real important.
I actually bring it up because I wonder, I think with the results that you presented today, and, if this really does have a major effect like this, then I think as surgeons, we have to always consider why don't we implant these electrodes at the initial operation? And, we do this for DBS, a battery runs for 8 years. Obviously 2 or 3 hours is a very different situation.
Well, that's going to be the question, is can we get to the point where we're looking at something that's implantable for the patient, that can increase their compliance, make compliance easy, and what's the current drain going to be on the battery? Are we going to be, now that Tesla and others are moving our battery density up, are we going to be able to get to a battery density that's going to last all day, and then they could put something on their chest to recharge overnight or something like that?
Yeah.
That would easily improve compliance, and certainly, given the impedance that there is from the bone, we ought to be able to drain less current if we're epidural or intradural with electrodes down the road.
Well, the data you present and the concept are clearly sound. The question, I think, in my mind, is where's it go next? And you've touched upon the immune response that could be leveraged. You touched upon compliance issues, engineering issues, and obviously implantable issues. And that's one of the things I was thinking too, Randy, and Dr. Thompson, is really just we as neurosurgeons, but more broadly as the audience will it extends beyond neurosurgeons. Are there opportunities to leave something present with the improved technology and battery approach? We're looking at something similar with focused ultrasound, where you can actually leave burr hole fixated ultrasound emitters and then just access those from time to time to do blood-brain barrier disruption in the form of clinical trials and other sorts of things. So I think the sky's the limit, but I must commend you on your work. It's phenomenal, and so glad you published it in JNO.
Well, thank you for inviting us. As I said, you and I may not be doing our residents will not be doing the same things we were doing of carving out big tumors down the road. My hope has always been in this field to get far enough down the road that we barely be needed down the road, except for doing biopsies and smaller things, and not have to do these huge heroic surgeries we sometimes do. So this is a step. This is clearly not enough to cure glioblastoma, which is a really resistant weed, as you well know. I'm looking forward to the advances that are coming along in the oncolytics and the dendritic cell vaccines, the CAR Ts. It looks like maybe moving immune checkpoint inhibitors earlier may have an impact. And this may give us a little something else. But if you look at the data here, we know we're making some impacts in our methylated group, but we've still got that huge group of 55, 60% who are unmethylated that we really haven't moved the rock very far in the last 15 years. Right. So you and I and the rest of the research community still have a lot more work to do.
Well, absolutely. Thanks so much. We have Brett Mulvey with us also from Novacure. I don't know if Brett, if you wanted to say a few words as we come to a close. We like to limit these to about 30 minutes or so. So if you want to end it.
Sure. And thank you, Dr. D'Amico. I appreciate it. So hello, everyone. And thanks for the great talk and discussion, Dr. Toms. I'm really excited to be able to represent Novacure, and I'll be very brief. I promise. I know we've already gone over a little bit. So my name's Brett Mulvey. I'm one of the MSLs with the medical team here. And on behalf of Novacure, I just want to say thank you for allowing us to support this Tumor Talk webinar. I will mention that Novacure continues to rapidly expand and develop our tumor treating fields therapy. We now have over 1,000 employees worldwide, so expanding quite rapidly. And in addition to our 3 FDA-approved indications, we do have 4 in our late-stage pipeline, which Dr. Toms did allude to a few of them. So again, thanks, and we're looking forward to helping support more in the future.
And I'll just add, just for clarity's sake, I appreciate the sponsorship. The sponsorship goes to the Neurosurgical Research and Education Foundation. It is not to the Journal of Neuro-Oncology, but this is a Journal of Neuro-Oncology initiative, Tumor Talk. But your support helps to go to a not-for-profit research and educational foundation for neurosurgical trainees predominantly. So that's where the sponsorship goes. But thank you so much, and hopefully it'll lead to some more breakthroughs in TTF or in other things that really are moving the needle, I hope, for patients with neurosurgical neuro-oncological processes. Thank you so much.
All right, everyone. Dr.
Toms, thank you.
Hey, thank you, everybody.
Great to see
Thanks,
you in the
guys.
test. Thank you.
Take care, guys.
Have a great afternoon. Bye-bye, everyone.
Bye-bye.
See you next week.